Jean Destandau, Endoscopic Surgery in Lumbar Spine Stenosis. Професор Лой в своїй презентації наголошував про Жана Дестандо. Hello, dear professor.
Hello.
Nice to see
Hello,
you.
good.
And nice to hear you.
Good morning.
Good morning.
Nice to see you.
Welcome.
This is my city, Bordeaux in France. And I thank you very much to invite me to participate to this meeting. I will speak about my experience in endoscopic surgery in lumbar spinal stenosis. It's a frequent pathology, and endoscopy is a great advantage for the treatment of this disease. I work with instruments I designed in 1993, and you know this device, and the main feature of this device is to be stable. It's not necessary to hold it. You just have to drive it with the hands, either the left hand with a suction cannula or the right hand with the instruments, surgical instruments. And of course, you use both hands to work inside. This is the orientation. We are on the left side. You can see the upper lamina. So up is on the left, the lower lamina, the articular facets, and the midline is up. It's the same thing here. You see the upper lamina, so exactly the same orientation. So spinal stenosis, you know, it's a rather frequent disease, and compresses the nerve root at one or several levels in the lumbar spine. The most important thing is to know that the compression is mainly due to the flavum, thickened flavum that is folded inside the spinal canal and compresses the nerve root. So the goal of the surgery will be to decompress the nerve root, so to create a narrow canal at the narrow level. You see post-op CT scan with good decompression and the spinal canal, a neospinal canal, that doesn't compress the nerve root. Same orientation, the upper lamina. I start to drill the lamina in order to have a thin bone, easy to remove with the Kerrison ronger, as you can see. And I look for the upper insertion of the flavum. You see the dura. And at this site, the spinal canal is wide, excuse me. So there is no danger to tear the dura or to damage the nerve root. Here I try to resect the base of the spinous process. It's to have space to the other side at the end of the procedure. And I go on laterally and along the nerve root that you can see. that lateral to the nerve root. I don't try to go to the most narrow space, which is very dangerous. So now the flavum is detached, and you see, I remove it in one piece, and at once the thecal sac expands, and it's very wide, and there is no more compression. No, not exactly, because on the opposite side, it remains some flavum and some bone, and you see that you can easily, because you have removed the base of the spinous process, easily access to the opposite side and decompress the opposite nerve root, as you can see on this slide. Another example, you see both sides, and the thecal sac has been decompressed. And this is the day of surgery, a lady who has been operated. And she's very happy because she couldn't walk anymore. And just after surgery, she recovered completely. So, in my mind and in conclusion, lumbar stenosis is a good disease for endoscopy. And endoscopy provides a double advantage, a direct advantage, because it's a mini-invasive technique, and indirect also, because I always try to treat as less level as possible. Thank you very much, and welcome in Bordeaux.
Thank you very much, dear Professor Destandau. In Ukraine, we call you father of triangulations.